Hi, my name is Jack Holland. I'm going to be talking about compartment syndrome today. Kind of a brief overview of compartment syndrome, some clinical manifestations, some similar musculoskeletal disorders that are kind of differential diagnoses of compartment syndrome, and lastly, some different etiologies of compartment syndrome. So initially, compartment syndrome is going to be most of the time caused from a trauma. Frequently, it's going to be a crushing injury. And essentially, it's going to be when the volume or the contents of a compartment increase. So I'm going to use kind of the running example of the calf muscle and the lower leg area. So briefly, it's going to be the fascia that's surrounding the calf muscle is inelastic. So when there's an increase in the volume, or if there's swelling or hemorrhaging, the fascia around the calf muscle is it can't expand or shrink. So it being kind of stationary is what's going to kind of give rise to the compartment syndrome and increase pressure in the compartment. So with that being said, some clinical manifestations. The first major one is going to be pain that's extremely out of proportion with the injury, which is going to be very sudden onset afterwards, and it can last for, if untreated, kind of right after the injury or the cause until a couple of days. Another manifestation is going to be paresthesias, because again, with the restriction or the pressure increase in the compartment, if there are any nerves that run through the compartment, so again, for the lower leg, you may have some paresthesias in the toes or the foot because the nerve is going to be compressed going through that compartment. So you may have some numbness or tingling or kind of burning sensation. And then now we're going to kind of move on to some differentials or some similar musculoskeletal disorders. The first one's going to be complex regional pain syndrome, which is also known as CRPS. So it's similar to compartment syndrome in the sense that the pain is severely going to be out of proportion. There's going to be an injury involved, but a major difference is the pressure in the compartment is not going to increase. That's not the cause. What the cause is that there's either damage to CNS nerves or peripheral nerves. So because of that, because there's damage to the peripheral nerve, it manifests a little bit differently. Patients can have temperature changes on the skin due to either vasoconstriction, dilation, kind of the abnormality of that nerve since it's now injured is kind of confused, so to speak. So patients also will experience excessive sweating sometimes to cool down skin temperatures that are elevated. Another major difference in that is the duration. This can be for 6 months or longer, and it's not perfectly understood, but it's essentially nerve damage to the nerve, which is kind of causing the pain that's out of proportion with the original injury. And so the next one is going to be osteomyelitis, which is going to be the infection of a bone. So for this example, again, we can use the tibia, is the tibia area. So it's going to be much more different in presentation. It's going to be much more gradual. You can think of any other common infection. You're going to have kind of a slow proliferation of the infection of the bacterial cells. And there's some similarities in the sense that, it could be the same area where kind of that same compartment area, but you can have tenderness to the touch or kind of pain with range of motion, things like that. But then you're also going to have systemic manifestations like fever and chills and malaise that are kind of more similar to classic infectious symptoms. So that's kind of the difference. It's going to be much more gradual. It's going to have some more systemic manifestations, and it's going to present kind of differently in that way. Another differential or similar musculoskeletal disorder is going to be osteonecrosis, which is the death of a bone segment. And it's not super common in the tibia fibula area, but it's going to kind of present in the same way as the osteomyelitis, where it's going to be much more gradual because the necrosis is going to slowly start to expand. So the patient originally is going to have pain with exertion, or in this case, weight bearing, since it's the lower leg. And then over time, it's going to progressively kind of shift towards where they're going to have pain at rest. So it's going to manifest, some similarities in the same. It can be in the same area, but some major differences are again going to be kind of the onset of presentation with the acute versus kind of gradual differences in that area. But those are kind of some similar things, especially with the CRPS, with the injury, kind of more trauma, that are kind of be some differential diagnoses for providers that they can kind of rule out depending on the presentation of clinical history. And then finally some etiologies of compartment syndrome. And compartment syndrome is kind of tough for diseases. So I chose some different etiologies that are kind of more broad to show. I think it's a little more interesting to see kind of what the different categories of possible compartment syndrome can be. So the first one is a major one, is going to be fractures. So fractures can either cause hemorrhaging or severe edema, causing the compartment pressure to increase, and then causing ultimately compartment syndrome. Common misconception is that a open fracture actually cannot cause compartment syndrome. I guess people think, logically, if there's, it kind of breaks the compartment, so to speak, where if your tibia was exposed, the fluid can kind of release. But, the edema still is going to, drastically increase in that area. And again, the fascia surrounding the muscle group cannot. So it's going to give rise to compartment syndrome, obviously not always, but in some cases. Another one is going to be deep venous thrombosis, DVTs. Not as common as the fracture, but if it's a large enough thrombus and if it's going to block a blood vessel, a vein that's large enough, or kind of a venous return that's large enough back to the right side of the heart, it can cause compartment syndrome. Again, because there's going to be no blood flow back through that major vein, so the pressure is going to slowly build in that compartment, which can give rise to compartment syndrome. Lastly, and this one I think is kind of interesting. Again, it's not a disease, but I think the etiology of it is, it's kind of more shows what kind of is capable of causing compartment syndrome. It's going to be alcohol and drugs. So a more local one you can think of is going to be like heroin use, which can cause local necrosis where it's injected, and also local edema. And depending on if it causes enough edema, which causes enough compartment pressure, it can give rise to compartment syndrome. And then one that's kind of not as common, but I think is interesting and worth mentioning as well, is going to be if you're prone for a very long period of time. So if you're inebriated with alcohol, or if overdose on heroin, for example, and you're anatomically in a kind of an awkward position where you can think of your knee being kind of twisted if a patient is down, and that compartment is compressed for long enough. Normally, if you were sober, a patient would wake up if they were maybe starting to have some pain or kind of difficulty with moving that lower extremity. But if you're inebriated or overdosed, you don't get those signals, so you stay in that compressed compartment position long enough to basically give rise to compartment syndrome, because the pressure is just building if there's, for example, not enough venous return. So those are some different etiologies that can give rise to compartment syndrome. They're not diseases per se, but they are disorders, and kind of different past patient histories that I think are interesting that can cause compartment syndrome. And that's all. Thank you for your time.